I'm going to probably refer mainly to mental health issues going through, though it does apply a lot to the learning disability agenda as well. But severe mental health has increased dramatically, certainly within the UK. Certainly the pandemic hasn't helped, but it was already on the increase, and some of the behaviours associated with that has also caused problems. And I think we need to also remember that actually large numbers of patients with mental health problems will also attend or be part of the wider healthcare system. So they're going to be in your acute trusts as well as within your within the mental health learning disability environments. They will be in care homes, they will be in general care homes, and they will be out there in the community. So this is these particular issues, I think, are not just ones that apply to those working specifically for mental health places. I think the other element about this is we always say IPC is not rocket science. Well, this is true, it's not rocket science. However, I sometimes think it might be harder than rocket science. So the basic principles are quite simple. The application of those basic principles are probably more complex than an incredibly difficult equation, mathematical equation, or trying to work out how to get a rocket up into the atmosphere. And I don't say that lightly, really, because I think the problem is that whilst IPC leaders would like to, part of us would like it to be black and white. It can never be black and white. It isn't black and white in your secondary care settings. It isn't black and white in your community care settings. So we really haven't got an area that's straightforward, really, that can really be well. And I think the other elements to remember is that infections and treatments, actually, and I can bring you back to a little story going back into my when I actually provided care, properly. I'm not saying I'm not a proper nurse now, but based on Rose's talk this morning, you started to wonder whether I was. But if I think about the certain issues. So I had a patient, I worked on a renal unit, we had a patient who was being given huge doses of methylprednisolone, and she became completely psychotic. Now, that wasn't down to an infection, that was steroid-induced psychosis. It's a recognised issue. But these are people that we're having to look after. And again, obviously because she had renal failure on top of her psychotic episode, her risk factors were increased. She had a cannula in, she had various other things that would cause it, which she removed herself. She had a central line in which she also removed herself as well. So that is, causing, you can argue that she's caused harm to self because of a psychotic episode, which we know causes risk. So this is happening in secondary care probably all over the country now, but we don't necessarily think about it as being a problem due to the mental health issue, or rather we do, but it's always thought of at that time. So there is huge challenges to us all, and anybody trying to keep service users or patients who are experiencing mental illness. So on the other, I suppose, the aspect is the fact that they do face a major inequalities, often through lifestyle, sometimes, I'm not going to say choice, but it's more, well, it is, I suppose it's lifestyle choices to a certain extent, but also just because of their illness sometimes puts them into difficult positions. And I think, and I'm going to go, so I actually wrote my master's dissertation over 10 years ago or something like that, and one of the areas, and the area I did explore was around how mental health, how IPC services were looking at mental health and a learning disability service. And actually a colleague of ours who is now retired, Dr. Julie Hughes, she was writing her thesis, her PhD thesis, on a slightly off-kilter, slightly different version, but similar subjects, because basically we both identified that very little research and the very poor evidence base to look at the particular problems, and no answers. There were no answers out there at all, or even indications. It was just, we need to look into it more, we need to look into it more. And I know, I'm just looking at Pixie now, who has also written papers on that to further, generate that information. So, but I think it can be divided sort of into three, these main categories that need to be looked at. Is actually, when we're looking at our patients with mental illness, what are their actual risks, that their mental health and learning disability issues has? Does it actually exacerbate their risks? Do they have other factors involved? I suppose the other part is, how do we respond as a healthcare community, either within the actual organisation caring for those, but also the wider healthcare communities that often have to put supportive processes in place. And then the other final point, I think probably that's valid, is do those caring for these groups of individuals, do they actually have both sufficient knowledge of their risks for infection prevention? Do they have understanding of how that can impact on their physical health and on their mental health? Do they have those skills enough present to mitigate against those issues? And I think, that's something I think we could all sort of really discuss to a certain extent. And I'm not going to go through all these different relative risks. I'll mention them as I go through probably. The big six, obviously, I'm assuming you'll all know, is MRSA, MSSA, C. diff, E. coli, Pseudomonas and Klebsiella. So they're the ones we are monitoring via the laboratory system to check on numbers. One of my points on that, is this the right information that we're looking for? When we're caring for patients in a mental health, and actually I'll put care home settings actually in there, it doesn't have to be mental health, learning disabilities, I would argue it's in care home settings. Are we actually looking for the right issues or even the infections? Should we be more generalising it to the disease rather than the organism? So whilst we do have to look at the organisms, obviously the mental health, learning disability, social care organisations aren't measured in the same way. They don't have the same reporting system because they often go through that acute secondary care provider laboratory reporting system. But the fact is, are they a true and are they a good measure of it? And I don't think, personally, I think there is, we need to be looking at different ways of doing surveillance, because I think we are probably all in agreement that if we understand the problem and we recognise the amount of the issue, if we know that we've got in our dementia care homes, we have 30% of our patients with that regularly have UTIs. What are the issues? It doesn't have to be all E. coli's or whatever. They could be any organism. The fact of the matter is you've got 30% of your patients with UTIs in a dementia care home or in a dementia facility. Why is that? And I think that's possibly the way we should be looking from a surveillance perspective. It's more around what is the actual disease process, because then you can start to look at, so are patients with dementia more likely to be incontinent? Are they less likely to drink adequately, to remain hydrated? Which, there's plenty of evidence that was talked about a bit yesterday to show that that's the case. If so, how do you manage that? How do we reduce those UTIs? Because let's face it, if patients get infections from, particularly where severe infections certainly, they often end up back into secondary care. Now, if you've already got a mental illness of any shape or form and you're blue lighted to ED, you wait for 12 hours minimum in the ED department. And let's face it, if you've got mental illness, sometimes it can be substantially longer that you wait in the area. Then you're already building in problems. You're increasing that problem. They're becoming more confused, anxious, and therefore their behaviours will start to worsen. So there's a very fine balance between how we manage our patients with mental illness, with an infection as well. So I'm just thinking about those. If we look at the main prevention and management, and I haven't put everything in again, I know there's an awful lot more, and we look at the oral hygiene, I mean, if we look at I can't remember what the number was now. I think it's something 90% of the population has gingivitis of some level. I'm sure that's what I was taught in the session before. And I know that within patients with mental illness, that's often substantially higher, again, possibly down to their behaviours. They're still often quite high levels of smoking going on. Their diets isn't so good. The drugs, often cause diabetes to occur. So they've got very many different things. So if we look at that, oral hygiene, just improving that might help reduce respiratory tract infections. It's this balance between the alls. The top one, if I'm looking at policy and guidance, what does policy and guidance tell us? I mean, I think if we're honest, a lot of the time, the guidance that's published is aimed predominantly at your acute settings, and it may mention mental health, learning disability, or even care home, social care settings, or community care settings. And what it tends to refer to is these areas are very complex, which is effectively all I've said, to be perfectly honest. And you have to have a discussion with your infection control teams. Now, that's fine where you've got infection control teams, but not everywhere has. And I think that's the other area that we need to potentially look at. So I'll probably refer to some of these areas as I move through, to be fair. So, service user risk factors. Now, I've already mentioned a lot of these because, it is around the comorbidities. They often have other ailments, sometimes caused by their medications, sometimes just because they're aging anyway, sometimes due to lifestyle. If you've got patients who cause harm to self, now harm to self manifests itself in many different ways, but pretty much all of them risk infections because they reduce your immune system. Whether you cause physical harm to cause cuts, or you are anorexic, so you're not adequately not adequate nutrition, whether you just refuse to have vaccinations, or general care, or you're dressing care for any wounds, there's different types of harming self, as well as the more obvious ways but that's also comes a problem. So there's obviously there's the risk of ligatures that ends up becoming a problem. Behaviour results in restraint. Now, the argument's always been about if you go for a cardiac arrest and how you manage your CPR, do you clean your hands before you start CPR? And I think generally the agreement is that you don't actually have to clean your hands before you start CPR, because CPR is probably more important at that moment. But the same applies if you've got a really difficult patient or difficult situation that's needing to be managed in a mental health setting. And whilst most mental health, most mental health nurses and learning disability nurses are taught very much to de-escalate a situation. And that's fine and good. It's not always successful. But actually, those of you that work in acute secondary care or within normal care homes, within care home settings or other non-specific mental health, learning disability settings, how many of you have had training in restraint, safe restraint? How many of you know and are confident in de-escalating a situation? And again, I can go back to the little lady, the psychotic lady that I had to manage. And to be fair, we had quite a few incidents on this, but she was tiny. She was only about 4'10". So I always remember it vividly because de-escalating it was nigh on impossible. The only person she would even talk to was one of my support workers. If I went close, she threw something at me. So it took, it was quite a danger, and she tried to strangle many other people. So it was a really quite a sensitive situation and frightening for the vast majority of staff, because actually she might be 4'10", but by golly was she strong. So You have to manage these situations and de-escalate, but how do you do it whilst applying your IPC processes and protocols? And that becomes an even bigger problem within the prison services and within your forensic services as well, so where you end up having to kit yourself up. We look at segregation, which can be a result of restraint sometimes, and we segregate patients into specific rooms. I have to admit, I couldn't remember what they were called. That was it. You know, I literally spent hours trying to remember what they were called. But I think the problem is you end up you put these patients in them. They are very restrictive in what is able to go in, what equipment is in there, how clean they are. To be perfectly honest, how they're cleaned pre and post individual being in there, and how it's managed throughout that duration. So, you know, soap is possibly not allowed in that situation. How does anybody clean their hands? At what stage do you clean your hands? What do you manage with PPE? PPE aprons could be used. And actually, it's all very well, I mean, I'm not going to argue about pools, but the reusable aprons are obviously going to be stronger and less likely to break. So if somebody tries to, if you're wearing an apron and you try to, and they grab hold of it, you're more likely to not get away with it very well. So I think all these things, all these issues have to be considered and measured when you're looking at the different risk factors facing how we manage IPC and get patients to be looked after, or patient service users to be looked after whilst they're in there. I think the other area, I suppose, to consider is about consent. We do need to gain consent of all. There is only so much you can do with assumed consent. And actually, with patients with mental illness, you can't make those assumptions, even if they're under a section. There has to be some ways of dealing with it. And actually trying to describe it, trying to manage that situation when you've got people with paranoia who feel who are conspiracy theorists, which our GPs are facing as well. You know, from that perspective, the general practice are obviously often see people with mental illness at possibly their lower before they reach crisis point, but they have to deal with people going in and effectively refusing treatment because of conspiracy theories. So they refuse vaccinations, they refuse basic treatment, but they might demand other things. There's that huge agendas around that anxiety and the depression. You can't be bothered to wash yourself if you're extremely, or potentially can't be bothered to wash yourself if you're extremely depressed. And at what stage does that from a hygiene perspective? Because obviously you need to have a level of hygiene in order to reduce your own risk to yourself of infections. If we want to test people, and I think certainly COVID highlighted this, is taking tests. We can't force people to be tested, though I would suspect that we tried quite hard to encourage heavily during the pandemic. But how do we make sure that they are tested and they are managing? And what happens when you get that positive result and you need to isolate them? Now, some organisations, you've got predominantly single rooms. So in theory, that should be relatively straightforward, except people don't always want to stay in their single rooms. And from a therapeutic perspective, you're getting them out. Need to keep an eye on the time. I talk too much, as we know. And then we add in the issues around stigmas and the various diagnoses. You know, if you have a patient with TB or with sexually transmitted diseases, because I think we do need to bring in this sexually transmitted disease element into this agenda, because obviously, well, not necessarily obviously, but numbers of individuals can sometimes be disinhibited. Therefore, they are potentially more at risk from sexually transmitted diseases, and therefore, when does that become part of the IPC agenda and the way we look at it and manage it? So we need to engage with them. I think that's what it is. As soon as we can, we try and engage with patients. Bring in the staff. Well, I've already talked about rocket science and the fact that it's not that easy. You know, what actually influences poor compliance practicalities. I think I've sort of illustrated a number of those areas. And it is around, hand hygiene, and cleaning is often common. You can't have hand rub or your point of care clean hand rubs at point of care, because there's issues around ingestion and misuse and being used as weapons. You can't look at even having soap in places. What type of soap? Do you have liquid soap? But then in that case, dispensers might be used as a ligature. So the issue isn't so simply about the staff not complying. It's about the staff being unable to comply. And then you can turn it on itself, because actually there are risks to the staff then of getting an infection from our patients. So it is really, really quite complex at times. And it's, how do we navigate that whole process? And it's this stage where I think I possibly oughtn't to say this bit. So we're looking at the this hand hygiene thing that we've talked about. Now I have two debates. There's part of me that's uncomfortable with it, which I'm sure a number of you possibly are, because it may disincentivize people to clean their hands. But is there a place for it in these less acute, these non-acute, non-surgical type settings where it's difficult? I don't know, maybe those are some of the explorations of different products that we need to look at and start to try and think about in areas. So I know they want to have a hospital trust, an acute setting. Actually, should they be looking at talking to non-acute settings, mental health, learning disability, care home settings, where sometimes product placement is hard just to manage it? It's a thought, I don't know. The other staff, we talked about the secure units and those with heightened risks. That can sometimes provide excuses. So that's where your behaviours. So I think sometimes the staff, it's not so much that they often can't do it in the standard way. This is where it becomes black and white and the many shades of grey in between. I refuse to use that number. So there's many shades of grey, and it's how do we empower our staff to think about their own safety and their service user patient safety, and put that balance in place. So they are putting in processes that can actually keep people safe from infections, so they don't end up in hospitals having IV therapies for prolonged periods of time, even though they ought to be only having it for short periods of time. But let's face it, that we know that doesn't count. So they don't end up in EDs becoming more and more anxious, just waiting until they get seen. And then there's all those issues around it, an infection exacerbating their condition. So I suppose it comes on to, if we look at the whole auditing and monitoring processes, when is good enough? When is good interrupting the transmission of infections? When and how do we know that? Because to be honest, if you're not doing adequate or any type of surveillance, it's very difficult to know whether what your interventions are working. So I think there are a number of risk factors, and they are really sort of, I suppose, based around, I don't know how to describe that carefully. So I think they just need to be really monitoring and thinking about how we manage those staff risk factors, really. So if we look at the environment, which is another area, a huge risk factor, and again, I mentioned this earlier, obviously, especially for those designed to be mental health or learning disability facilities, they are often designed specifically for their therapeutic value rather than their reducing the risk of infection value. So, they have to be robust enough to be able to deal with the challenges of that particular population. But they also need to think about the other issues. So we want them to be well ventilated from an IPC perspective. However, we put grills and mesh in place and stop them opening the windows properly because of the other risks involved. You know, if we look at those other core IPC requirements, such as put in where you put bins. How do you manage the bin situation? The lids, can they be used as weapons? You know, it just goes on. I've talked about the hand hygiene facilities and placement. Cleaning, who does what, where and how? Is it acceptable to say that patient service users clean their own rooms? How can we feel confident they're adequately cleaned? Do we have a right as IPC practitioners within mental health and disabilities? This is probably less of an issue in care homes, but do we have that right in those to insist that that they are cleaned to a sufficient standard? Is that again around that engaging the service user to bring them along with us as much as possible? Because you could argue that it's actually therapeutic to. Well, I would argue that it's therapeutic to clean your own room. But again, that's something that often is, you know, it's taking free will potentially, where they've got very little control over what's happening to them. So that is maintaining their small bit of control. So it's how can we as IPC practitioners negotiate that difficult conversation, really, both with the staff, because there is sometimes a reluctance, they see the issues, but it's the difficult conversations that they don't always necessarily feel will be beneficial to the service user for their specific mental health issue. You know, it's what are the risks? You know, even the cleaning products. You know, you've got to lock everything away in triplicate, pretty much, very, very secure, because of the risk of ingestion, the risk of people trying to harm themselves. You know, and it's that balance, and how do you manage it? You've got to manage it somehow, or is it just about choosing your product so that if a service user does get hold of it, does drink it, whilst they might not be very well, they would still live. And that would be my option. It might not be the gold standard according to the guidance, but if it's sufficient to clean and has and complies with the relevant EN standards for decontamination, then actually should we be considering those as options for cleaning? I mean, I mentioned also the issues already about the containment areas. So we look at the IPC services. I mean, I don't know how many of you are from, but but recently, you know, when we've looked at IPC services, and the ones I know that look after mental health organisations, and I know a few from mainly in the north of England, north of the Midlands anyway, they're all designed very differently. Some have large teams, partly because they cover community and as well as the mental health and learning disabilities areas. But others are tiny teams. Even though they've got what would appear quite a big bed stock, they might only be a one-man band, possibly with an assistant. Others have got teams of, I don't know, certainly 10 I know of. But that is, you know, has multiple things. And I think that's not helpful either. Because actually, how does a one-man band looking after a 700-bedded organisation with 40 separate sites actually manage the IPC issues in each of those areas? How do they manage that whole role that they're supposed to be looking at? You know, how can they even deal with the different risks and balances and checks and balances with all the areas that they need to? And part of it, I suppose, is that most of these organisations will also have physical health teams. So there needs to be a level of collaboration and discussion, and that can amplify it. But again, that's not always perfect and doesn't work. And we commission or contract out substantial amounts of our mental health work to private providers. How are they actually managed or looked after from an IPC risk perspective? Are they? Do they? Is there an active service going in? Oh, I've got the red light already, and I've got about 10 slides left. So I mean, what I'm trying to really get to from that perspective is, you know, that it's difficult. The aspect is made worse by, I'm going to keep going for a bit longer. The aspect is made worse by, or made even more difficult by the issues around leadership. You know, in order to get anything moved in a IPC in mental health, you do need to have full engagement from your exec and leadership teams, and whoever the DIPSI is really needs to come on board, otherwise it doesn't work. And you can use, and they need to lead by examples, and they need to get those commissioned and uncontracted issues sorted out as well. So if you're contracting services or commissioning services, the needs and the IPC requirements need to be stipulated, that there is something looked at. So, sort of sampling and surveillance and use of data, I have talked about this a little bit. He's not waving at me yet, but he will do. And so if I look at the sampling, we talked about the issues around consent. Many of you, some of you will have, those of you that work in mental health or even for care homes, you may take your sample, it'll go to a lab. Which lab does it go to? Some of you are using multiple labs. So how do you make sure all your information is coming back so you absolutely know what's happening? I think, again, the laboratory surveillance is very much organism-based. And whilst you can use it, it can be helpful from a sporadic case and things like that. I think it can be bigger issues. And I talked already about the increased risks of UTIs and RTIs in your dementia care services, but actually that also applies to your older adult mental illness services as well. I mean, there is evidence floating around that patients with a schizophrenia diagnosis also have an increased risk of staphylococci infections. Now, that might be down to they've also got an increased risk of type 2 diabetes, and again, that population group has an increased risk of staphylococcal infection and abscesses and things like that. Obviously, we know that patients who are abusing substances, particularly through IV routes, are again at higher risk of those areas. So that's another aspect that needs to be considered. I'm getting there, nearly there. Education and training. Well, what have we been doing in the pandemic? Everything's gone online. No face-to-face. And I don't know whether, certainly in the early doors of the pandemic, it became very clear that staff that worked within, well, pretty much all facilities, to be honest, but care homes, mental health, learning disability organisations were not confident. They may have received some training, but they possibly would have been part of that mandatory training for infection control and possibly hadn't been listened to as well, or their workbooks weren't done or were copied. We've all done it. So I think there was a definite lack of understanding going on, and I think it's not just, it's about that. I think they've got to the stage where they understand the transmission routes of COVID, but actually how does that apply to all the other organisms? You know, how does that apply to their C. diff, the risks around antimicrobial prescribing, because they are prescribed antibiotics. Oddly enough, just because you're a mental health patient, you are prescribed antibiotics. So how is that managed and looked at the different transmissions routes? It's about engaging with staff at every level, and I've always found simulated learning, joining in with the restraint training, was probably the most successful. When I was working with for mental health, I did simulated sessions, because actually the education teams within mental health are quite happy to do role play a lot of the time, much more than those of us that work and only work in general situations normally. So they were quite happily pretending to be someone with dementia, with a UTI or a chest infection. So I think, you know, we have to get the physical health. It can amplify, the messages can be used. So if you're doing a news scoring training, put the IPC element in with it. is my suggestion. And then finally, final thoughts. Applying IPC principles is complex. We need to be more innovative in about how we collect, what information we're getting from a data perspective, how do we know any improvements, how do we know what our actual burden of infection is, because we have to provide evidence that there is actually a burden of infection for people to take it seriously, for them to realise that their treatment, their patients, that their service users' mental health or mental status is actually worsened because they've got an infection, whatever the type of infection is. Look, I think it's a case of working with building and equipment designers as well to look at the safety of the products, so we can work with them so they can get into challenging environments. So we need to work about that more secure stuff. And I think finally, we have to acknowledge that this group of patient service users, clients, whatever we want to call them, are absolutely integral to our main healthcare. And therefore, we really do have to identify those solutions, not just for that specific organisation, but also for that wider care settings, from GPs to care homes to the wider system. It has to work across the system. And that is me finished.